Welcome back to the Metro on WDET. I'm Robyn, Vincent. Mental health crises too often land people in jail instead of hospitals. That's what happened in Traverse City, where this weekend a man attacked 11 random Walmart shoppers. According to his family, he had suffered for decades from bipolar disorder and schizophrenia, and he, quote, fell through the cracks of the system again. Meanwhile, in Manhattan, 4 people died after a shooter opened fire in an office building housing NFL offices. The gunman pleaded grievances in a note tied to suspected brain injuries and noted a mental health history. These incidents remind us why reforming the system and the people who interact with it matters. In Wayne County, nearly half of the people in jail are medicated for severe mental illness, and 911 received over 15,000 mental health calls last year alone. Over the past decade, a coalition of groups has been working to change how we respond to things like mental health crises in Wayne County. Since 2016, jail bookings here have dropped more than 50%. Police now receive specialized training. Social workers ride alongside officers, and mobile crisis teams sometimes respond without law enforcement. At the center of this transformation is Dr. Cheryl Kubiak. She's the founding director of the Center for Behavioral Health and Justice at Wayne State University, and she's also dean of Wayne State's School of Social Work. Her team has led pilot programs, built shared data systems, and worked to break down silos. Today, she joins us to share what's working, what still needs to change, and how communities can respond before crisis turns to catastrophe. Dr. Kubiak, thank you for joining us.
Thank you, Robyn. It's wonderful to be here, and particularly to follow Andrea Smith, who's a colleague and close partner in this work.
Let's begin, if we could, with a simple question that gets to the heart of your work. You've spent years studying what happens when people in crisis encounter police, courts, and jails instead of getting care. Why do so many people with serious mental illness still end up in jail first?
Well, it's a very complicated issue, and often resources in any particular community are not prepared. The other issue is that systems often work in silos, and so you have law enforcement over here, courts over here, the community mental health over there, and there's little opportunity to work across sectors. And that's really what our work is to facilitate that collaboration across systems and people in communities all over the state.
And that is something that has really struck me about your work is the way you have been able to connect organizations and systems and people who, as you said, were working in silos. But I want to think for a moment, if we could, about how things have been. And so in that light, how does that first point of contact, often with law enforcement, how does that shape everything that follows for a person?
Well, first of all, 911 is generally the crisis call we make. 988 is coming, and I want to advertise that. 988 is a specific crisis line that is staffed by mental health professionals. It's been well publicized, but not well accessed. So 911 is the first call people make. Generally, there's EMS or law enforcement that respond to those calls, and anything that looks like it may be at risk and mental health calls are generally fielded by law enforcement officers. Historically, law enforcement officers haven't had the training that helps them identify when it's a mental health crisis or when it's quote-unquote bad behavior. Many law enforcement officers have told us through the years that when they see a person in that level of distress, they assume it's bad behavior, particularly before they've had any of the training, that CIT training that Andrea Smith, again, has been really involved in. But when that happens, at DWIN, yes. Yeah. When that happens, when law enforcement answers that call, they have two options. And it's either going to an emergency room, a medical emergency room or a jail. If they go to a medical emergency room, they're often waiting in the waiting room with this person because they can't leave them. And sometimes it's as long as 8-10 hours waiting in an emergency room, taking them off the streets. It's much easier for an officer to take someone to jail at that point, especially if they're shorthanded in the community. So that's the first part. That's how it starts.
And so, Dr. Kubiak, you walked into a system years ago that was deeply fragmented. This is something that you observed, this problem that you just described. And you also observed that more broadly, police, hospitals, courts, and community mental health agencies weren't speaking to each other. Mm-hmm. So what did it take to start breaking down those silos?
It's been really interesting, but I think that in a nutshell, it's collaboration and knowing each other as human beings. Too often we heard initially that it's their problem. And what I say at the beginning of every community session is this is a community problem. It's not a police problem. It's not a jail problem. It's not a CMH problem. And if we don't all work better and more efficiently with the limited resources we have, the problem will continue and exacerbate. So there's preconceived notions generally of different fields about the other. But what we found when we could sit them down in the room and say, okay, what are you experiencing? What are you experiencing? How could we do this better? And we would facilitate like just monthly conversations. They started to see each other not as professionals in a specific discipline, but as partners and problem solving together. And that breaking down those barriers was essential. We went from some places where they were very derogatory, the jail administrators were talking about the CMH folks. Within a year, they were going out for beers together. Mm. And that kind of human relationship is really important for breaking down those silos.
Let's go back to the scenario that you were painting of the person who is either going to end up in the emergency room or in jail. Mm-hmm. What's happening now instead of that scenario?
Well, we've got a crisis, a behavioral health emergency response initiative that we've been launching statewide with the help of state administrators, the Michigan Mental Health Council, and local communities. And really what we're hoping is that 911 operators could be better trained to identify when it is a behavioral health issue. And once they identify them, learn about how they can triage them. So when you were referencing the mobile crisis units going out alone, when you look at two axes of what the acuity of the problem is and what the level of risk or safety is, then you can start to match what's the best response option. Is it a mental health provider? Is it somebody we can talk to on the phone? Or do we need to send law enforcement?
You helped launch crisis response models across the state, from mobile units to co-responder programs. What do we now know about what actually works when someone is in crisis?
Okay. First, I want to say that we facilitate, and that's our primary function. It is really the collaboration in the community that have stood up some of these. But what we do know, we did a study of who responded. And what we found is that if it is mobile crisis that's responding, individuals are much more likely to get into continuing treatment and less likely to end up in jail compared to a law enforcement only. Co-response is kind of in the middle of that in terms of the outcomes, but we do know that transitioning some of this to the appropriate system is more successful in achieving the long-term outcomes, which is someone is functioning in a healthy way in the community, right? They're not cycling in and out of the jail over and over because they're in a treatment unit. They're in the appropriate system.
And Dr. Kubiak, this reminds me of one of the most striking outcomes of your work, which it sounds like this is all quite connected. And that is that Wayne County cut jail bookings by 52% between 2016 and 2024. So talk a little bit more about the story behind that number, if you would.
Okay. 6 years ago, we started the project with the support of Andrea Cole from the Flynn Foundation, Judge Freddie Burton from the probate court, Tim Kinney from the circuit court. And we came together and said, what can we do about this problem? And it launched a collaborative project where systems came together, and the numbers that you quoted around the calls to 911, the 15,000 calls, that there was an embedded clinician in 911 right now in Detroit that is fielding those calls. There's interventions much earlier at the probate court with a behavioral health unit in the probate court. There's diversion programs at the level of the jail. There's deflection programs for law enforcement to recognize behavioral health. So this collective project was an incredible experience, and I've got to give a shout out to the team, our team at CBHJ, Stacy and Nancy, who've been at this from the beginning, but just facilitating that collaboration. And I think the success of this story belongs to every single agency representative that chose collaboration versus competition. Every leader who shared data across like those traditional boundaries where people said, no, we don't want to share our numbers. And every frontline worker who went above and beyond to be innovative about the care they gave.
Dr. Kubiak, one finding from your evaluation has stood out to me. I mean, many have actually, but only mobile crisis teams, not police or co-responder models, led to this statistically significant drop in arrests, something that we've been touching on. But plenty of communities still default to law enforcement. One concern is sending clinicians into unpredictable crisis scenes without police. What do your data and field experience suggest about how to keep clinicians, clients, and communities safe in these moments that feel really unpredictable?
Yeah. Well, I think that the first thing is that sharing of data across systems. Like CMH is often, our community mental health agencies often knows who folks are in the community, but sometimes cannot exchange that information with law enforcement. So we have to have mechanisms, because as we can see, this can be a life-threatening situation, right? So I think that is one thing. But the other thing is this opportunity to triage and also respect the skills of the various professionals. One of the things, and I'll give you an example, that we've seen in jails and in prisons as well as on a call, is that often what officers are trained to do in the academy is techniques that are very aggressive and very like take control, because they often deal with very unsafe situations. But that behavior can actually escalate an individual and create more psychiatric symptoms that will cause either harm to other individuals or self-harm to that person, or put the officer in a position where they feel fearful of their own life. So I think those are things that we have to do. The other, and I want to mention this, is the assisted outpatient treatment. Assisted outpatient treatment is through a probate court judge and really helps people get the medications they need, even if they're resistant to taking them, and puts them under court surveillance. It's seen sometimes as a more coercive interaction, but I think that rolling that out to communities, so there's something in between jail confinement, risky situations, and people functioning at full capacity.
So you're trying to really take a holistic lens here in offering a lot of different levels of treatment and support. Dr. Kubiak, before I let you go, I realize you've now shifted focus to Michigan's juvenile justice system. And I want you to very quickly, in the last 30 seconds that we have, tell me what's one thing we consistently get wrong when it comes to how we respond to youth in crisis?
I think the first thing is understanding what the context is and how their mental health is operating, and making sure they get those resources first. That's the prevention, right? And that's what I think we need to bring in. It's not always a court issue. Again, it's a community problem, and that intervention and prevention up front is the most important thing.
Dr. Cheryl Kubiak is the founding director of the Center for Behavioral Health and Justice at Wayne State University and dean of Wayne State's School of Social Work. Thank you so much for joining us on the Metro.
Thank you, Robyn. It's been a pleasure.
This is the Metro on WDET. Coming up, a rooftop garden at the top of the Arab American Museum in Dearborn brings the homeland home. That's next on the Metro after the news from NPR and WDET. This is WDET FM, Detroit Public Radio, your connection to news, music, and conversation. And this is the Metro. Stay with us.